It's a pleasure to be here. Thanks very much for inviting me. So as you can see here, I'm going to talk about the work that we're doing to improve the approaches that we take for treating nicotine dependence. So before I get started, let me first disclose that I am a slave to industry. I always hoped to eventually rise to the level of having disclosures. So it's great that we do receive a lot of support from Pfizer in particular for free placebo and medication supply for our clinical trials. We've received some support from GlaxoSmithKline in low-cost nicotine replacement therapy, and I've provided a consultation to both of those companies in the past, and I'm going to be talking about their products throughout the talk. So I'm sure I don't have to spend too much time belaboring the point that we should be doing something to further drive down the rates of nicotine dependence in the U.S. A third of all cancers are attributable to tobacco use, about 500,000 deaths a year. It's really expensive and it drags our economy down, hundreds of billions of dollars. But importantly, and this is what we try and emphasize obviously to all of our participants that are enrolled in our clinical trials, you can do something about it. In fact, there's really persuasive epidemiologic data that shows that if you can get somebody to quit smoking by about their mid-30s, that by the time they reach 65 years old, their risk of developing a tobacco-related disease is the same as someone who's never smoked in their lives. And we have numerous studies that demonstrate that smoking cessation interventions are highly cost-effective. So this is a slide that kind of depicts the mission of our lab. As David mentioned, the rates of tobacco use, this is national epidemiologic data over the last 10 years. And the point I want to make by showing you this slide is that we've really plateaued in our achievement that we made over the last 50 or 60 years. So one of the most monumental public health achievements to date is that we've driven down the rate of smoking in the U.S. from about 50% in 1960s to about 20% about the turn of the last century. But we've really plateaued. So we've been hovering around somewhere around 20% for about the last 10 years. And the reasons for this plateauing may have to do with the fact that only about 1/3 of smokers who utilize evidence-based treatments for nicotine dependence are able to quit smoking. And the vast majority of smokers who do make a quit attempt don't use evidence-based interventions. There's some data that suggests that only about 6 out of 100 smokers who are making a serious attempt to quit smoking are utilizing guideline-based behavioral counseling and some FDA-approved medication. So what can we do to address these two sort of causes of the potential stagnation in the success that we've had over the last 50 years? Well, there are 3 areas that our group has been involved in. The first is developing new, more efficacious medications. But I'm sure many of you are aware of how costly, how expensive, and how slow the pipeline of developing new medications really is. So NIH has been really supportive of the idea of repurposing medications. So taking medications that have been approved for other indications, but they may address some of the symptoms that may underlie relapsing back to smoking. And so potentially looking at those medications for nicotine dependence. We've tested a number of these like modafinil, and now we're looking at acetylcholinesterase inhibitors. And we've developed a screening procedure so that we can know very early on within the first few weeks of a quit attempt whether this is a medication that may show some kind of signal of efficacy. I'm not going to spend any more time talking about that area of work, but what I really want to spend more time in is talking about the work that we've been doing on improving the efficacy of existing treatments. I'm going to talk about sort of 2 stories in that area, one looking at extending the duration of treatments for nicotine dependence, and the other focused on personalizing the selection of treatments based on a genetic variable. And then I'm going to talk with you a little bit about, at the end, about the work that we're doing to promote the use of evidence-based interventions in different clinical populations, and then the work that we're hoping to move into with clinicians. So let me tell you the first story that focuses on the extended use of nicotine replacement therapy. We started with nicotine replacement therapy because this work was started back about 10 years ago prior to the approval of varenicline by the FDA. So we chose nicotine replacement therapy, and we chose the patch in particular because there was a lot of data to suggest that it was the most popular approach to treating nicotine dependence. This is VA data that compares utilization of the nicotine patch compared to bupropion and the nicotine gum, showing that where the arrows are, that the nicotine patch was the most favored approach to treating nicotine dependence. It's still extremely popular, still the most popular approach to nicotine dependence treatment because compliance generally is better than with other nicotine replacement therapies. And the degree to which it replaces the amount of nicotine that a smoker was getting from combustible cigarettes is higher than with other nicotine replacement therapies. And it also has a very attractive side effect profile, meaning that it doesn't yield that many serious adverse events. Now, these are data showing that only about 1 out of 4 smokers who use the nicotine patch are able to quit smoking. And this is a compilation of studies through Cochrane reviews and through USPHS guidelines, emphasizing that we can certainly do better, hopefully, than the data suggest. And we argued at the time that some of the limitations around the efficacy of the nicotine patch have to do with the labeling of this medication. So I'm sure many of you work with people with long-term addictions, and the idea of bringing them into a clinical trial and providing them with 8 or 10 weeks of therapy and saying goodbye, good luck, is unrealistic and naive. So we argued that we need to look at whether or not we can adopt the same approach that we use for opiate dependence with nicotine dependence to see if that can improve the 1 out of 4 rate of success with the nicotine patch. There wasn't a whole lot of data out there to help guide us at the time when we started this study. There was a Cochrane review in 2008, and it was since updated in 2012 that looked at indirect comparisons and direct comparisons. So the indirect comparisons looked at the odds ratios of success in studies that provided treatment for less than 8 weeks, or the odds ratio for studies that provided treatment for more than 8 weeks. And it was 17 versus 26 studies. But there was very little control for the variability across these studies in terms of duration, in terms of the dose that the patch was used, in terms of the inclusion of adjunctive behavioral counseling, and in terms of the outcome measures that were used to evaluate efficacy. So there were potentially a great deal of confounds underlying this no difference that was found. There was a direct comparison, but and again, it was also not significant, but it only involved 3 studies that had samples each of less than 50 individuals in each, and we all are firmly aware of the concerns that we would have in such small samples. There was one controlled trial at the time. This is Phil Tonnesson from Sweden, the CEASE trial, which was the only large placebo-controlled trial at the time that had systematically looked at whether short-term therapy for nicotine dependence involving the patch was less effective than long-term treatment. And it found no significant effect, but it only used continuous abstinence as the outcome, which we widely recognize, at least in the smoking cessation literature, as a very conservative measure of outcome. We now recognize point prevalence abstinence with a biochemical verification as the gold standard of evidence, knowing that that these medications often act as rescue therapies, that individuals cycle through repeated durations of lapsing and recovering, and then in the end may recover. Yeah, David, feel free to ask me any questions.
I was going to ask, in the
Yeah.
earlier studies that you reviewed, what was success? What was considered success?
In the Cochrane reviews, the outcome measure is typically a 7-day point prevalence abstinence, biochemically confirmed, and same with the UPHS guidelines, and usually at least a 6-month outcome. Yeah. So, at the time that we were starting our study, we were hopeful because of some simulation data that existed at the time. And in this study, they used computer simulation to look at the risk of relapse when individuals were given 8 weeks of therapy versus those who were given a longer-term course of treatment. And these are the relapse rates that they suggested. So the thick line here is the risk of relapse with standard NRT, and this is the risk that was projected through simulation if individuals were maintained on therapy, and they estimated that about 50% of relapses could be avoided through the continuation of treatment. And I want you to remember that 50% rate, because I'm going to come back to it in a minute. So this was the study that we conducted. It was a randomized clinical trial, a large sample, over 500 individuals. After eligibility screening, they were randomized at baseline to be on 21 milligrams of transdermal nicotine. We did not use the step-down method. There was very little evidence at the time that the step-down method was any more or less effective than just providing people with steady dose. And there was also a practical reason why we kept people on just the 21 milligram, because in manufacturing the placebos, it was extremely costly and difficult because the different doses also come in different sizes. So you're faced with the practical difficulty and the cost challenge of manufacturing smaller amounts of placebos in different sizes. So for practical reasons, and because there was no evidence to suggest that it was any worse than a step down, we kept people on therapy for 21 milligrams, and then at 8 weeks they were switched on to a placebo, and then they were followed up for 12 months. The other arm received 21 milligrams of transdermal nicotine for 24 full weeks. So this was these are the main results of our analysis. So this is logistic regression models. We control for a lot of different covariates that were associated with either outcomes in terms of cessation or retention. And these are common covariates that are controlled for in analyses like these. So these are separate logistic regressions at different time points. And this is the standard 8-week arm, and this is the extended 24-week arm. And you can see here that there's no significant difference in the quit rates at 8 weeks, but at 24 weeks, we found a significant increase in the likelihood of cessation in those participants who were kept on the extended therapy arm. But at 52 weeks, the quit rates were the same. Yeah, you can go. Yeah. Yeah. It's the end of treatment for the 24-week arm, yeah. So we had looked at a survival analysis as well, wanting to hopefully see what Medioni and his simulation data had found. And so these are hazard ratios that represent the difference between the treatment arms and the likelihood of relapsing back to smoking. So here we have 100% of the sample who are abstinent at time point 0, and we looked at their relapse at week 52, when relapse defined here as 7 days of continuous smoking following a period of an abstinence. So for the first 8 weeks, the hazard ratio is 0.79, no significant difference between the two groups. But our hazard ratio was exactly 50%. I'm not making this up. I swear that this is exactly what we found, that the likelihood of relapsing back to smoking in those who were kept on the extended therapy arm was 1/2 of that rate for people who were in the 8-week arm. And then the hazard ratio was not significant for week 24 to 52. We were also interested in really verifying the importance of the 7-day point prevalence abstinence compared to a continuous abstinence measure, and also theoretically trying to understand what keeping people on therapy could mean for them and how it could explain that the rates were so much higher at week 24. So we conducted these regression models focused on lapse and recovery, also broken down, stratified by the time points here. So the lapse model, what that is looking at is the likelihood that an individual on any given day would move from a state of abstinence, so 24 hours of not smoking, to having 1 puff of 1 cigarette on the next day. That would define a lapse. In the recovery models, it's the opposite. So in those models, what we're predicting is moving from a state of 24 hours of abstinence to having a puff, moving from a period of smoking to a day of abstinence, not having a single puff of 1 cigarette. So again, Similar to our cessation outcome data, but for the first 8 weeks, no significant difference in terms of predicting lapse, but between weeks 9 and 24, there was a significant reduction in the risk of lapsing to smoking for those who were kept on therapy for 24 weeks compared to 8 weeks. And the opposite was found for recovery. So again, no significant difference for the first 8 weeks, but for that time period between week 9 and week 24, there was a significantly greater likelihood of recovering back to a state of abstinence if you were on therapy for 24 weeks compared to 8 weeks. Yeah.
So, is what your data showing that once someone is going off the nicotine replacement therapy, so in the weeks 25 to 52, it all equalizes regardless of the dose up until that point?
So are you commenting on the fact that between week 25 and 52 there's no significant effect? So that was our next study, right? Which I'm going to show you right now. Right, I didn't get her to say that, I swear. So, but before I get there, we were invited after these data were published down to the FDA to present these results, and it eventually helped contribute to the loosening of the FDA labeling on nicotine replacement products to allow smokers to talk to their physicians, and if their physicians were okay with it, to stay on therapy for a longer period of time.
Was it originally there as a safety feature? I mean, is there any evidence that staying on the pack is any harm?
None whatsoever.
Then why was it?
Probably for a FDA is very risk averse, and so I think to avoid the possibility of risk, I also think that there is a fundamental philosophical assumption about nicotine dependence being an acute condition that people have far more control over than they really do. And so the idea that a short-term therapy is sufficient is probably pervading a culture there. Yeah.
This also extended to pregnant smokers? Is this loosening the restriction?
No, we didn't have any women who were pregnant or lactating in our study, so we can't comment on that. My understanding of the literature on NRT in general for pregnancy is that it's not very effective. We've just started a Bupropion study that I'll talk about near the end for pregnant women. So to pick up on what your comment I think was suggesting was what happens if we keep people on therapy beyond that 24-week period? Can we really see that it's about maintaining people on therapy indefinitely like we do with methadone or other treatments for opiate dependence? So that was the next study that we conducted. It was an effectiveness community-based study because by this point NRT was became over the counter in 2008. So it was so widely available that there was no way we could do a clinical trial like we did before. So we did this as an effectiveness study, no placebo. We had an 8-week arm, a 24-week arm, and now a 52-week arm. The inclusion-exclusion criteria were really modified to allow more people into the clinical trial to make this to be more of a real-world trial of whether or not maintaining people on treatment for a longer period of time increases quit rates. And this is what we found. So this should give everyone hope when they find null results in their study, because I've made a career off of it. So again, these are logistic regression models. We control for a lot of different variables in our model. So what we're looking at here, when I say off treatment at week 24, this is the 8-week arm versus the 24 and the 52-week arm. So this is replicating what we saw before. Our quit rates were quite a bit lower because this is a community-based sample, but we found support for what we found previously, that keeping people on therapy out to week 24 was still more effective than 8 weeks of therapy. But now when we looked at week 52, the off treatment versus on treatment, here what we're looking at is the 52-week arm versus the 24-week, and the 8-week arm, we did not find a significant effect. We were really incredibly disappointed and really shocked by this. So we delved deep into sort of trying to understand what that was about. And one of the explanations is adherence. So we looked at adherence in a number of different ways. So here in this top figure here, this is just the average number of patches that individuals use per week. And the maintenance therapy arm used significantly lower average number of patches. And then if we looked at, when we defined the proportionate adherent, and we defined proportionate adherent as those who were using the patch on at least 6 out of 7 days per week, every week, we found that the maintenance therapy arm was the lowest at the degree, lowest in terms of the proportionate adherent. And we also found adherence was a very strong predictor of cessation in our outcome models. We also interestingly found that something sort of happens at week 24 to these participants. That we looked at just in the maintenance therapy arm, we looked at the average number of patches that were used per week, and they were, they were lower up to week 24, but after week 24, the adherence, really started to drop further. So it was the proportion of maintenance therapy participants who were adherent between weeks 25 and 52 was significantly lower than that same group between weeks 1 and 24. So we have a daily record, like a diary, self-report, yeah. It's tough because if they're smoking, so you can measure nicotine, a metabolite of nicotine, but if they're smoking, it's going to be confounded. So you can measure, there's another metabolite, I think anadabine, and so you can measure nicotine and anadabine and see, and anadabine is not sensitive to NRT, so you could remove those smokers who just show positive, positive anadabine and nicotine, and then just take the nicotine positive people. But it's super expensive to do. Yeah.
Was this effectiveness trial open label where everybody
Yeah.
knew what they were assigned?
Yes.
Okay.
Yeah. Yeah. Yes.
Do you have, on the measure you used,
Yeah.
there wasn't any significance. I would hypothesize that there was less smoking in the maintenance group.
Mm-hmm.
Is that, did you have self?
We have those data. We have.
Are there,
Yeah, we haven't looked at it. So
because if
that.
they were using the patch, even at a lower level, they may not be abstinent, as
Mhm.
measured, but they may be smoking fewer cigarettes. If they
Absolutely.
Take off the patch already.
Absolutely, yeah. It's true, and we have those data and we can look at it. So that sort of harm reduction argument is a little bit more controversial in our field than
Yeah.
it may be in other areas of addiction, because we really don't have good data to show that smoking 5 cigarettes a day is better
Yeah, no,
than
the-
smoking 10 cigarettes a day.
No, the medical data in
Yeah.
terms of lung cancer anyway,
Yeah.
from what I've understood is that duration is weightier than intensity.
Right,
So
exactly.
4 cigarettes a day
Right.
is, 8 cigarettes a day is not necessarily
Yeah.
twice as bad as 4 cigarettes.
Exactly. So that's why we don't. I don't typically look at cigarettes per day as an outcome measure, but it's completely plausible that
Mhm.
that it's driving down the smoking rate.
I'm
Yeah.
also
Yeah.
wondering, for those people in the maintenance condition,
Yeah.
at some point in time, after week 24,
Yeah.
I've been doing well with my patch, I'm sick of my patch. At some point, I'm gonna be like, do I
Right.
wanna be patching
Right.
my entire life?
Right.
So I
Yeah.
might start decreasing
Right.
my adherence just because I'm thinking, I got this good. I can
Right.
do that."
And along those same lines, the mechanism underlying the patch efficacy is reducing cravings. And so the further away you get from having successfully quit, cravings is likely to be a weaker predictor of relapsing back to smoking than, say, social cues that you're facing in your environment. So we may be thinking about keeping people on a therapy that isn't really going to address the risks associated with their lapsing at that point. It's true.
Is there any
Yeah.
people working with long-lasting nicotine patches because they don't have
Yeah. Right. Not that I know. Not that I know of. It's a good idea though. Yeah.
Oh, just
Yes.
similar to that, like if there was a difference, like other than a patch, like some other kind of, something that's less intrusive,
Mhm.
like maybe people will, yeah, do better with that, but.
I'm sorry, I didn't catch the gum.
How does the drop off like compare, do you know, with like just general, like people's medication taking for any kind of chronic condition?
That's a good question. I don't know. I think our adherence data look very similar in this study to our previous study, except the maintenance therapy arm is still pretty low. These folks kind of resemble what we've seen previously. But we feel pretty confident that something's going on in the subgroup of people who are asked to stay on therapy for such a long time, that there may be some reactiveness there that is countering the therapeutic intent that we're hoping to have. Okay. So what we conclude at this point is that longer-term treatment with nicotine patches can improve treatment efficacy, but we're really uncertain that there are any significant benefits beyond 24 weeks of treatment. We feel pretty confident that we sort of understand the process underlying long-term therapy, that at least out to week 24, that a large role is played by reducing the risk of lapse and promoting the likelihood of recovery. And although I didn't show it here, but in both studies, we have really persuasive data that there are no adverse side effects, no serious adverse events from keeping people on treatment, even out to 52 weeks. Any questions about that before I move on to the next story? Yeah.
I have a question and
Yeah.
comment about what John was saying. Is there any data that shows, you mentioned that reducing the cravings may no longer be the primary driver.
Yeah.
And as an ex-smoker myself, I know a big part of what was missing was the sort of like the habit of it, the ritual of it. And I wonder if reducing the number of cigarettes may eventually help reduce some of those sort of ritualistic aspects of it. If you're not having a cigarette at the specific times of day where you usually have them, or in the social environments, if there's any sort of predictive value in the reduction.
We can go back into our data. We do ask people about the pleasures from different cigarettes at different time points. So we can go back and look at like the hedonic aspects of smoking and see if there's reductions in that. I don't know of any good measure of like the sort of broad ritual aspects of smoking, and we certainly didn't include that. But we do have measures of the hedonic aspects of smoking, and to see if the reinforcing quality of smoking is going down among those maintenance therapy.
That show like reductions in number of cigarettes correlated with ultimately reducing to none?
No, I don't know. It's a good question. I should know that.
It seems like the methods for
Yeah.
I know it's probably a function of the way you get your funding and how you have to run your study. The methods do often always seem to be like, here's the day we want everybody to quit.
Yeah, right.
And then we're going to track you
Target quit
from
date,
this
yeah.
point. And, it does make you wonder, the rates are always so low in this field, like of getting people to quit or getting people to achieve abstinence. And then when you guys talk about it, you're talking about 7 days, like, oh, we sampled you at 7 days and they were not smoking then. All right. It seems as though there's got to be some more rethinking of like how you partner with somebody to perhaps more slowly reduce their use to build up to quitting. I don't know. I mean, it's like you almost think like you got to coach people for a year before you get to that target date to get them down to a level where they're going to be ready to make the switch.
Yeah, for some people, it's a recovery process not unlike we think of other addictions.
Sure,
where
sure.
it could be, first there's the repeated failures, right? But then in addition to that, some of the successes may be a 3-year, 5-year story.
You're working your way up.
Listen, if I could get a 10-year R01,
Right.
I would get it. It's not for lack of trying.
Yeah.
So I mean, I think you bring up like 5 or 6 points there. I mean, I can't address all of them, but there are other researchers that are looking at different innovations in the process. So 2 that come to mind that I think speak to what you're suggesting is a longer pre-quit phase. So you're right. We typically randomize, do a baseline assessment, get a pre-quit counseling session, and then at 1 week after that, you have a target quit date. And we expect you to quit smoking, and then that sets the anchor for that 6-month outcome in the observation phase. And some of the methodology may be incongruent with how we should be approaching treating nicotine dependence. So other people are working on broadening that pre-quit phase, adding more sessions, allowing people to take nicotine replacement therapy for a longer period of time pre-quit, and then and some of those data are showing better outcomes than the approaches we take. So you're right. And then another study that comes to mind about sort of innovating how we're approaching treating smokers in this way. There was a terrific study just published a couple weeks ago in JAMA that looked at unmotivated smokers. So people that are saying to you, we're not looking to quit smoking right now. And this study used varenicline, placebo-controlled, and showed that even with smokers who are not motivated, like our smokers, to enroll in a smoking cessation study, if you put them on varenicline, you see the same kinds of quit rates that you see in the general population of treatment-motivated smokers. So that there are other people, like me, that are doing kind of more innovative things to tinker with the people and the methods a little bit and getting better outcomes that way. So you're absolutely right. So let me talk with you about the work that we've been doing in the area of personalized medicine to see if we can develop a therapeutic algorithm that improves efficacy. We focused our work on the liver enzyme CYP2A6 and the variability in the rate at which individuals metabolize nicotine. So this is a diagram that just shows you that about 80% of the nicotine that's ingested from having a cigarette is metabolized into cotinine and into 3-hydroxycotinine. That's the primary metabolic pathway through which individuals metabolize nicotine, and there is variability in how slow or how fast this mechanism operates across smokers. There are a range of genetic variants that inactivate this enzyme. So turn individual smokers from being generally rapid metabolizers of nicotine into really slow metabolizers of nicotine. And this is just the frequency from our colleague up in Toronto, Rachel Tyndale, that just shows you the frequency of these variants in the population. There are some that completely inactivate the CYP2A6 enzyme, turning people into like super slow metabolizers of nicotine. And then there are other variants that just decrease the activity, turning people into sort of slowish metabolizers of nicotine. And we have found over the years, our group and lots of other groups around the country, that variability in this enzyme is related to a range of different smoking phenotypes. It's related to nicotine. It's related to cigarettes per day. So if you're normal or a faster metabolizer of nicotine, you're smoking more cigarettes each day. When you are in situations where you can't smoke and we assess withdrawal symptoms, if you're a faster metabolizer of nicotine, you experience a higher rate of withdrawal symptoms. And these data over here just look at measures of nicotine dependence, showing that if you are, again, a fast metabolizer of nicotine, you show higher rates of nicotine dependence. But the rate at which individuals metabolize nicotine is influenced by a range of different environmental factors as well. Gender is one of the strongest factors related to the rate of nicotine metabolism, and this is work from our colleague Neil Benowitz, who showed in terms of the rate of nicotine clearance and the rate of cotinine clearance, when you compared men and women, and then when you compared women who were on an oral contraceptive versus women who were not on an oral contraceptive, you see really very strong estrogen effects on the rate of nicotine metabolism. So women are faster metabolizers of nicotine than men are, and then women who are on an oral contraceptive are much faster metabolizers of nicotine than women who are not on an oral contraceptive. And race is also another strong predictor. I don't know if, here. Race is also a very strong correlate of the rate of nicotine metabolism, but it's a very complex story, so don't cheer too soon. So, so we're looking at it, but it's a really complex story. So these are data looking at the rate of nicotine metabolism described as in quartiles. So if you're the quartile 1 or the lowest quartile of this distribution, you are the slowest metabolizer of nicotine. If you're in the 4th quartile, you're the fastest metabolizer of nicotine. So you can see here the gender effect. So women, about 28%, are in the fastest quartile of metabolism and compared to men. But look at the story with race. Complete opposite distribution here, and a very striking linear increase in the rate of metabolism for Caucasians compared to African Americans. So look at the slowest group here. About 42% of them are in the slowest quartile compared to only about 16% of Caucasians. But it's a complex story because, as I'm going to show you, the slow metabolizers are based on our data, far easier to treat than fast metabolizers are. But that doesn't jibe with the data that we find in our clinical trials about African Americans and responding to treatments. So it's a really complex story. I should just say that BMI is also a factor. When you're on, you can take a range of different medications that influence that CYP2A6 enzyme and influence downstream metabolism of nicotine. So one of the problems, though, with just focusing on genetics to understand the rate of nicotine metabolism is that we don't have all of the CYP2A6 alleles identified at this point. Do you have a question?
Yeah, I just had
Yeah,
a question. Do you
of course.
include socioeconomic factors into account at all?
In what data? In these data?
Right. It would just be interesting to see,
Yeah.
how socioeconomic
Like
fits
income, like
into-
income and education.
Right, it fits into rates of.
Mm-hmm. No, I'd be happy to share those data with you if you want to look at them. We have not. This is just very, crude comparisons based on their self-report of race and ethnicity.
Yeah, I'd be interested.
Yeah, sure. I'd be happy to share them with you. I don't know of anyone that has looked at those measures in relation to NMR, but we can. So one of the problems with just using genotyping to identify individuals as slow and fast metabolizers of nicotine is that we don't have all of these alleles identified yet. So it's impossible to classify everyone. It's also extremely difficult and costly to assess. You need very specialized labs to be able to do this, and it takes a while to LCMS procedures are expensive and time-consuming. So our group has verified and moved to what we call the nicotine metabolite ratio. And this is a value of the two primary metabolites of nicotine, this 3-hydroxycotinine and cotinine. And we have shown is that if you look at the ratio of these two metabolites, it gives you a very reliable and valid estimate of the rate of nicotine metabolism. And here you see data across different genotype groups and the rate of 3-hydroxycotinine to cotinine. And this is the stability of this measure over time in smokers. And we've shown that it's, the test-retest reliability of this 3-hydroxycotinine and cotinine marker is quite stable. It can be easily measured in a number of different sources. It's independent of time since last cigarette. So we have validated this sort of genetically informed biomarker based on the metabolites of nicotine as a valid and reliable marker of the genetic and environmental variability in the rate of nicotine metabolism in smokers. Yes?
I have another question,
Of course.
Relating to race also.
Okay.
Like black people like menthol cigarettes more than
Uh-huh.
white people.
Mm-hmm. And there's an interesting relationship between menthol and the rate of nicotine metabolism.
Yeah, how does that
Mhm.
fit?
So we have a paper coming out soon. I'm not present. I didn't think about presenting it here, but I can certainly share it with you. Yeah. So menthol induces CYP2A6 metabolism, so it speeds up metabolism. So it makes this story really even more complex because you've got these really slow, generally slow metabolizer of nicotine using something that's inducing CYP2A6 activity, that's speeding up the rate of nicotine metabolism. So the data that we have so far is really more just descriptive and showing that it is likely an important characteristic in how African Americans smoke that needs to be considered in the eventual algorithm that I'm going to show you. Yeah. Sure they did. Of course they did. Yeah, of course they did. It's been known by researchers. Yeah, yeah, and it's been known by researchers as well for a while too. But it's sort of a very interesting story to understand how smokers are being manipulated into enhancing the addictive quality of their behavior. Absolutely, yeah. So we've been using now this NMR marker that's based on the 2 metabolites of nicotine to understand how it may be useful for tailoring the selection of treatment for nicotine dependence. So we've looked at this across a number of different studies. Many of these are very large studies. You can see here the distribution of gender and race, cigarettes per day. FTND is the Fagerstrom test for nicotine dependence, age, and then the 3-hydroxycotinine to cotinine ratio. The first study that we looked at this in, this was very exploratory. The first set of studies I'm going to show you here are all retrospective analyses, meaning that we had conducted these clinical trials without any knowledge of the importance of this nicotine metabolite ratio, but as we were understanding it in greater detail, we went back into these studies. We were fortunate enough to have collected a DNA sample, so we went back into these studies to look at how this characteristic moderated response to different interventions. So this was the first study that we went back to look at how it related to response to the nicotine nasal spray and the nicotine patch. And these were the first study. This was the first study that, where we showed that there was some relationship between the quit rate across the quartiles. So here again, we have the quartiles of this nicotine metabolite ratio. Here are the slowest metabolizers of nicotine, and here are the fastest metabolizers of nicotine. We have EOT data and 6-month data. The dark blue are the patch, and the pink are the sprays. And we found a significant relationship in terms of the quartiles of the NMR and response based on whether you got the patch or not. So if you were in the first couple quartiles, about 45% of smokers were able to quit smoking at end of treatment, compared to about 26% in the fastest quartile. But there was no relationship between the nicotine metabolite ratio quartiles and response in the spray condition. And we replicated this at the 6-month follow-up. We also looked at whether or not this had to do with nicotine levels, because back in 2006, 2007, we were just convinced that this was a very sort of simplistic story, right? That, you know, you're just metabolizing nicotine very quickly, so the onset of withdrawal and craving is much sooner, and if we only kept you on nicotine at steadier doses, we could prevent that from happening and boost your quit rate. So we looked at blood levels, and this is in biochemically confirmed abstainers at 1 week after therapy, and we looked at the blood levels across the quartiles, and we showed here that there was a significant reduction in plasma nicotine levels across the quartiles for the patch group. Now, we didn't see that in the spray group. In fact, the spray group showed higher levels of plasma nicotine in the highest quartiles because they could take more doses of the spray to compensate for their fast rate of metabolism. Now, don't get too excited about these data, because it's not consistent with what we think is going on at all anymore. So I just want to show quickly that we've replicated this in our initial duration study. We replicated this in our recent maintenance therapy study. And then, thinking that this all had to do with nicotine levels, we set out to conduct a small proof of concept study where we just took the fastest metabolizers of nicotine and randomized them to 21 milligram nicotine patch plus a placebo patch, or 2 21 milligram patches of 42, so that they were getting 42 milligrams of nicotine. And we were really, again, disappointed, again, building my career on null results. These were the quit rates that we got. There was some, slight signal that those who were in the high NRT group showed some initial improvement in this is 24-hour week 1 abstinence. This is the first 7 days of cessation. This is just a 24-hour cessation at week 8. But in terms of sort of the gold standard that we use at 7 days, there was a slight increase in the high NRT group, but it wasn't significant. And there was certainly better nicotine replacement, but we found overall that it was a pretty weak signal for a high-dose nicotine replacement therapy for the fast metabolizer of nicotine. And at the same time, we had some data coming out of our Bupropion study. So this was a trial where smokers were randomized to Bupropion in counseling or placebo in counseling. And we really just engaged in this study, in this analysis, sort of in a whim. We were, again, still pretty convinced that it had to do with nicotine replacement levels, but then we were really shocked by these results because Bupropion doesn't affect nicotine levels at all. It's Wellbutrin, so you're probably all very familiar with its mechanism of action. And it has nothing to do with nicotine replacement. But when we looked at our data, here's end of treatment and 6-month outcomes, again, stratified across the quartiles of the NMR, and looking at quit rates. In the placebo group, so this is just counseling, we replicated what we found previously, that there's a real liability to relapsing back to smoking if you were the faster metabolizers of nicotine. But look at the quit rates in Bupropion, completely wiping out the liability to relapsing back to smoking across the quartiles. In fact, the fastest metabolizers showed the highest quit rates. So we're really stunned, and I'm sure many of you understand how difficult it is to find these kinds of interaction effects between treatment and some kind of moderator. And we found it here at the end of treatment, and then replicated it at 6 months after the end of treatment. And again, so this has nothing to do with nicotine levels. So this really kind of confused us as to what the mechanism of action of this nicotine metabolite ratio is. So we had set out about 4 years ago now to sort of take the next step to conduct the first prospective study where we would up front test individuals in terms of their nicotine metabolite ratio, identify slows and normal. We had to oversample for the slows because the cutoff in the population reflects about 1/3 for slows and about 2/3 for fast. So to conduct a stratified clinical trial like this, we had to kick out a lot of the normal or the fast metabolizers at the initial phase of the study. And then they were randomized to placebo, which got a placebo pill or a placebo patch. They got an active patch and a placebo pill, real varenicline, and a placebo patch. And we picked varenicline because it was the best-in-class FDA-approved medication, and we also had some pilot data to suggest similar results to what we saw here with Bupropion, that the fast metabolizers were responding really well to varenicline. Yep. Brett Chantix. Yeah. Or Champix if you're in Canada or the UK. Don't know why, but they call it something slightly different. Sure, a lot of focus group analysis went into that decision. Okay, so this is what we found. So this paper just came out last month, and we were really excited to find what we found. And so here are the quit rates by slow and normal metabolizers. We have end of treatment, 6 months, and 12-month data. This is quit rates again. So I should have said this earlier, but this is 7 to 8 point prevalence, biochemically verified. Placebo, nicotine patch, and varenicline. So at the end of treatment here, when we look at the slow metabolizers of nicotine, no significant difference between patch and varenicline, same at 6 months. But when we looked at the varenicline data, we found a substantial increase in the likelihood of cessation for the fast metabolizers who were given varenicline, both at the end of treatment and maintained here at the 6-month follow-up. And another interesting aspect of this study is that when we looked at side effect data, we found that the fast metabolizers on varenicline showed no significant differences between patch and varenicline. Sorry, the fast metabolizers showed no significant differences in side effects between patch and varenicline. But the slow metabolizers reported a significant increase in side effects on varenicline compared to the patch. So these data suggest a potential algorithm before I get to that, that can improve efficacy and reduce side effects. So to summarize, we've spent a lot of years on the marker development, sort of identifying this NMR as a valid biomarker of nicotine clearance that takes into consideration genetic and environmental influences on nicotine metabolism. We think we're on pretty firm ground in suggesting that these slower metabolizers of nicotine can do well with just counseling or the patch. Oh, really? Okay. And but fast metabolizers need varenicline. And what we're moving into now is our next step of work, looking at disseminating this and implementing it and hopefully translating it to clinical practice. So I think I've just got 3 or 4 more slides, and let me summarize what we're working on now in the area of improving the use of evidence-based interventions. So we have an ongoing clinical trial with cancer patients. This is work that I've been involved with for about 15 years now. A lot of these patients continue to smoke even after the diagnosis. It's related to poor clinical outcomes. There's no smoking cessation randomized clinical trial that's yielded significant effects, including several of my own. And largely, we argued that this had to do with inability of clinical trials to address some of the unique barriers to cessation, one of which is the protracted timeline for relapse. So being diagnosed with cancer is probably the most effective treatment for nicotine dependence. You get virtually everyone to quit smoking. But by 6 months, about 70% of them have relapsed back to smoking. So, and in the general population, when people quit smoking, about 70% relapse within the first 72 hours. So we argued successfully that we need to do a varenicline extended therapy study with this population. So we're about 2.5 years into this clinical trial. We have 125 patients randomized so far. For my progress report that I just put in last week, we reported the 12-week outcomes in the first 125 patients. In the general population clinical trials that were used to support the FDA approval of this medication, the quit rate at 12 weeks was 50.3%. It's 49.5% in our clinical trial. So we're really optimistic for 2 reasons. One, that we're replicating what we see in the general population with cancer patients, and 2, that the quit rates are nice and high here to see a big drop eventually in those who then are switched on to a placebo for the next 12 weeks.
What kind of cancer? Is it
Any kind of cancer, yeah. Yeah. So we can stratify by tobacco-related versus non-tobacco-related.
Is it like a third lung cancer, a third throat cancer, a third everything else, or do you know?
I don't know. I don't know. No, I don't know. I didn't report that in our annual report. I've been doing these clinical trials for a long time, so you have to really cast your net wide in order to make it feasible. So this is work I'm doing with Dave. He, I'm sure, is regretting letting me into his office a few years ago and convincing him that we should work on something together. But we were fortunate enough to get a grant together looking at varenicline for the first time in a very traditional randomized clinical trial. The rate of smoking is exceptionally high in this population. It's related to poor clinical outcomes, and so this is a study that we are conducting to demonstrate safety and efficacy in smokers with HIV. We have about 100 people in this trial so far. We have not looked at any of the cessation rates so far because it's a blinded clinical trial from the outset. This is a study that we just had funded a few months ago. It's a study that focuses on depressed smokers. We know the rates of smoking among those with psychiatric comorbidity is exceptionally high. Here you see some of the different conditions like schizophrenia, and MDD is here about 60%. In fact, smokers with psychiatric disorders die 25 years earlier than the general population. This is a complex factorial study. We're we're hoping to demonstrate the safety and efficacy of varenicline for this population, but we're also testing for the first time behavioral activation therapy, a unique approach to behavioral counseling that is based on behavioral economics. And so we're hoping to show that we can boost varenicline's efficacy by adding a novel behavioral intervention that has been shown to be very effective for treating depression. And we also have some data to show that it's related to outcomes. Because of time, I won't go into it, but this is data that just supports our behavioral activation therapy, showing that it's related to cessation outcomes. And then I mentioned to Yukiku that we have a trial, this is Hank Kranzler's grant that I'm involved in, with pregnant smokers looking at bupropion. Sort of an interesting story with bupropion. It's the second most commonly prescribed antidepressant for pregnant women. There's really good safety data after the first trimester. And so you saw earlier the data I showed you with oral contraception use and metabolism. So we argued that pregnant women are very fast metabolizers of nicotine. In fact, there's really good data. I reviewed a paper that's coming out soon that showed that pregnant women are extremely fast metabolizers of nicotine. And as you saw earlier, we have good bupropion data to suggest that it's an intervention that can be effective for fast metabolizers of nicotine. We just started this study a few months ago. We have less than 10 women who've been randomized so far, but we're hoping to demonstrate the safety and efficacy of bupropion for pregnant smokers. So I'll end there and thank, of course, everyone that I work with and our different agencies and supporters. So thanks very much.